6 years ago, the world was hit by COVID-19.
Kenya has confirmed its first case of COVID-19.
I want to inform you that the Ministry of Health has confirmed the first coronavirus case in Kenya.
What did we learn? Did we learn anything? Have those lessons informed how we are planning or how prepared we are for the next pandemic?
People are afraid of me at work. I can't even get close to anyone.
In the event that we get struck once again.
We have to pay the bill. Of course, we have to clear that bill 3.8, of which are 2.
Welcome to today's episode of Echoes of Evidence. I'm your host, Lilian Motengo. Today, we are going to be talking about COVID-19, and we want to look at it from two different perspectives. One from a frontline worker, and the other perspective is from somebody who approaches or tackles health care issues and systems from a policy perspective. So, Prof, what was your experience as somebody in the policy space when COVID first broke out?
COVID-19 broke out at a time when we actually least expected it. And I can say that it surprised many of us. I remember very well that we had actually just had our annual IANFI, International Association of National Public Health Institutes meeting of all directors in Addis Ababa. And we were talking about how prepared we are as a continent. And then we come back, that was in December 2019. And then we come back, all of a sudden, we are in a total crisis. So you can imagine that kind of scenario. But from the Ugandan perspective, if I may talk from the Ugandan perspective, is that we have actually been fairly prepared, but not to the magnitude, of course, COVID put us in. And so, because of the many outbreaks we've had, we actually managed to put so many things in place. We have so many guidelines. We have policy, directions. We have a number of systems that we have actually put in place that you would say probably helped us. And we were actually even in the alert phase of Ebola when COVID struck. So we kind of transitioned from our alert phase of Ebola to COVID-19. So, but if I talk about it in the continental perspective, I think from the Africa CDC perspective, is that we had actually discussed a lot about that. And there are also a lot of frameworks that we had actually put in place that were supposed to guide countries in response. And so I think we were moving towards preparing for something similar to COVID, but we were not ready for the magnitude COVID put us in. So much as I can say that countries actually had put in, policies, response structures that would make us respond, the magnitude of COVID more or less made us think twice whether we had actually done a good job.
Just speaking from what you have said, you were at the tail end of Ebola when COVID hit. Did I get that correct?
There was Ebola in Congo. Now we were of course following very keenly what was going on in Congo. We of course Congo is a neighbor, and we were following. So we even discussed it actually during our meeting in Addis Ababa. But from the Ugandan context, we were on alert phase because we were expecting Ebola to hit anytime. So, but Ebola did not hit. That Ebola, whatever, did not hit. It was actually a Congo one. We had the imported Ebola, which we nipped in the bud. In 2019, if you read what happened in the Ugandan context, we had 4 cases that all actually died in Uganda, but they were all imported cases. Yeah, so we were actually in that state of saying, we can easily have Ebola as a community outbreak, but we never had it. We only had imported Ebola, but we were ready for it. So we transitioned from that readiness to COVID-19.
Okay. Esther, as somebody who was at the front line when COVID hit, you know, what was the situation like within a hospital setting? What was it like? What was the atmosphere like? I'm just trying to figure out at that moment when, you know, news is breaking out, this is a pandemic. It's actually something that you're dealing or hearing about for the first time.
It was chaotic. Reason is nobody knew what, if a patient came in, as much as we were doing the triaging, you were trying to avoid this patient has this disease, this patient has disease. It was very chaotic. It is very unsettling, may I put it that way. Because a patient with COVID-19 will come, obviously some patients were Google patients, let me put it that way. They'll go to Google and see this and this and this. So when they come to the hospital, they'll tell you, I have a cough and I don't have a fever. I have a headache and I don't have this. So you as the frontline worker need to assess this patient and try to read beyond what this patient is telling you. Because most of them were very afraid of being isolated, being away from their family. So getting to pinpoint this patient has a COVID-19, you had to stress the patient to a point of breaking point, and he tells you, at some point, I was in contact with a patient with COVID-19. I'm afraid that's why I'm not telling you the truth of the matter. Okay. So the patient will go for the COVID-19 test. The COVID-19 test, as you've seen it or you've done it, it's not a very interesting procedure. So patients were also afraid of going through that. But end results, you had to protect yourself, the healthy patients, let me put it that way, and the COVID-19 patients.
How are you protecting yourself?
We had the resources. You had the mask. A mask was then every day. It's like waking up and putting your ornaments or makeup. You had to have the mask, basics, mask. Then you have the face shields. And now, if you're a frontline worker, you had to have the mask and the face shield. But now if you go past the outpatient, you may put it, our casualty, you had to have the white gown. See? So it depended on where you were working. Was it casualty? Was it the HDU? Was it the ICU? Was it the wards? Are you like attending to the COVID-19 patients or you attending to their other patients? So the dress code, let me put it that way, the COVID-19 dress code was different for everybody.
At this time, protocols were rapidly changing and information was still emerging. How were you dealing with this constant changing environment around all this, information, protocols, all the time something new is coming up?
In our profession, we are taught to adapt. You have to adapt like this. What comes, you adapt with it. You have to go with it. You have to be flexible. Every day was a learning procedure. Yes, you have to adapt to the situation as it comes. COVID-19 patient today is mild. Casualty is mild. Goes to HDU is severe. So you have to adapt with the situation.
Prof, when we look back 6 years today, what do you think were the most important lessons Africa learned from that experience?
I think in a way, COVID was a blessing in disguise for Africa.
Oh, really?
Because I think we had also slept for too long as a continent. So COVID woke us up. For me, that was the biggest lesson we learned. COVID made us realize what it means to lead in a war. When you want to see that a leader in a war is critical, you have a serious war. That's when you realize that. COVID made us learn that. Where there were decisive leadership, you would actually see things move. And things started changing around that. So many African countries actually moved and decided that, you need to take leadership. And, literally in all countries, the leadership for response actually moved to president's offices. we know all this happened to State House. It doesn't happen in other things. So for me, that was a lesson that when things turn bad, take leadership. But also that leadership did a lot. It made us actually act quite fast. You remember what happened about border controls, about movements, about heightening surveillance across border countries in Africa, about lockdown. Countries put lockdown and people stayed home. Apart from us, of course, who are responders, who are moving up and down. So that showed leadership, and that was a lesson we all learned. And then the other lesson I think that was critical was, you remember when we introduced the integrated disease surveillance and response systems way back in 2000. That is actually when it was introduced by WHO Afro. And so African countries adopted integrated disease surveillance and response systems at different stages. But I can tell you that countries that actually made very critical use of the IDSR responded better. They were able to pick cases better. So we also learned the importance of real-time data systems. For me, that was critical. The other thing is about community-based surveillance. So when we're introducing community-based surveillance, a lot of people say, is it very important? How do you engage the community in ensuring that you pick alerts early? We learned a lot from there. The other thing, of course, was about the lab networks. So those are critical things that we learned around the surveillance systems. And then the other critical thing which we learned, actually, that even made Africa CDC come up with very, very fundamental changes. Was we learned that dependence on global supply chains or money from other people or vaccines from other people or even external technical support doesn't work quite well for us. It actually exposed our vulnerability. So that if you remember how Africa CDC came up with the public health order, the new public health order, I was part of that. And so that new public health order for me was a game changer. Because if you look at the way we now look at national public health institutes in Africa, because one of the pillars of Africa CDC. Now, we are literally moving towards all the 55 countries in Africa having national public health institutes. And of course, the relationships with academia, the relationships with the ministries of health. So that strength of the institutions that support response was critical. The other one, of course, was the workforce, the critical cadres of workforce that are responsible for response. Key things, field epidemiology. Many people, some people would say, what is this field epidemiology training programs? That is where people actually realize that field epidemiology training programs is a game changer. It is actually the engine for public health surveillance. And now many other countries that did not even know are actually adopted that. And after that, actually, Africa CDC came up with Africa Epidemic Service, which incorporated the three components of health informatics, laboratory leadership, and then field epidemiology. Those are lessons we critically learned around that. And then, of course, the other one, you all know about manufacturing of vaccines, where we were denied until COVAX came on board and then helped us actually to access vaccines. And then we said, no, we can't continue like this. So one of the new public health order facets is manufacturing of vaccine, diagnosing, and therapeutics. So without COVID, we would never have thought that we could actually do this ourselves. And then, of course, the major one is domestic resources for health security. We were relying too much on donors. We say, you know what? Is this the way we're going to do it? Many countries got. In Uganda, if I give an example of what we did, the goodwill of the community, actually the community became philanthropists. It was not only the businessmen, but many other people actually gave in whatever. We actually collected a lot of things, which actually, if they were put to use, it was good. And then, of course, the other thing is about the way we collaborate in Africa. The goodwill we gave Africa CDC even expanded, and we learned that collaboration is the way to go. You can't do everything alone. You need others. So we learned all these things because of COVID, because COVID struck everybody.
Prof, you've said so much about all these things, the surveillance, the laboratory capacity, collaboration across, different public health institutes. And there's so much that you've, brought in there. But we are now 6 years in. How much of this progress has been sustained?
One of the things for me, I think, which we have sustained was the public health emergency operation centers. Because if you look at the components of national public health institutes, much as there are countries that have established public health emergency operation centers as standalone, we actually learned that you cannot have public health emergency operation centers standalone. They have to be part of the response system of the national public health institutes. For people are now learning lessons. So those who are now moving towards legislation on national public health institutes can't leave public health emergency operation centers out. The other thing, of course, which for me I think is sustained, is the decentralization of public health emergency operation centers. It's not only now national public health emergency operation centers, but getting regional. And even some people are going lower down, literally in all countries that have established their national public health institutes. For me, I think they have sustained that. The other one, of course, which has been sustained is technical capacity. Because most of the countries now actually have capacity building programs for field epidemiology training programs. Even if they have not gone beyond to laboratory leadership, to health informatics and others. But at least I think it's fairly sustained in many of these countries. And I believe that they know the value of how these people work. And then, of course, the other thing is when you look at the data management systems, what we did in DHIS2, there are a lot of expansions in terms of dashboards, in terms of capturing alerts, and all those. Those have never gone away. Those have all been sustained within DHIS2. And for me, it's quite a good thing. And then, of course, the other thing is, as I mentioned about National Public Health Institutes earlier on, apart from public health emergency operation centers, they move towards legislation. Literally, as I say, literally all countries now, the 55, are going to have national public health institutes by 2028, believe me. So for me, I look at it as that's a sustained momentum, which was brought about by COVID, and now we know that it is the way to go. And then, of course, the other one is about PPEs, personal protective equipment. Many countries did not have gloves. Uganda inclusive, we were never manufacturing gloves. We were not manufacturing aprons. Now we manufacture aprons. We have never stopped manufacturing aprons and gloves.
Nice.
Now, imagine we couldn't even do this before COVID, but now we have done it and we have maintained it. And now most of the supplies of gloves and aprons in Uganda don't come from outside. Mm-hmm. So for me, I think those are critical examples. And then, of course, one of the things, of course, because remember I told you about the new public health order. They are now sustained. It's actually streamlining health systems in Africa. Mm-hmm. So I think in a way, much as, of course, we have challenges of funding, but you realize that actually many countries now have actually decided even to put some token money at least for response, not 100% relying on foreign donors.
Esther, how do you relate with what he is saying? PPEs, being able to protect yourself as you provide care to others in need.
In terms of resources, since we are all unprepared, truly spoken, the resources, the PPEs were not as sufficient as they were as the pandemic was going on. So at first, we were all okay because we were still adapting to what disease, but at least we had the basics, the masks. But now, being a nurse and a patient, wow, it was very mentally exhausting. Because as much as you care for the patient has come to you with the symptoms, you're still at risk of getting the patient. Me, being a health worker at some point during the months, I got the COVID-19. But now turning out to be a patient on the other side was a bit, you're getting anxious because COVID-19, you've been taught about it. This is what you expect, but you don't know the extremes. For when you are the nurse or you're the doctor, you're seeing the patient. You're able to attend to the patient. Giving care was easier than giving care to yourself.
Just tell us about that. Emotionally and professionally, what did that mean to you? How did that affect you?
Attending to patients was easy, let me put it that way. Because being a nurse with so many years of experience, you're attending to the patient the same way you'll attend to any other, leave alone the COVID-19. So it's a bit of the experience.
Yeah.
But with a COVID-19 and you don't know if the patient will give you the COVID-19, you're trying to live in a bubble.
Yeah.
You might not get it. I'll be safe today. Tomorrow is another day. You wake up. Going to a hospital was more of like a health hazard because you don't know what day it will get to you. So when it finally got to me, being the other side, now you're the patient. You actually feel what the patient was telling you. Now you get to experience it. It's not very easy because you're used to telling the patient, this is what's going to happen. For me, actually, when I got tested, I didn't go to the facility I work for. It was one of the off days. Then I was like, let me go. I'm having these symptoms. I don't want to go through the procedure and I don't know how bad it's going to hit me later. Let me go to another facility. So I'm there seated like a patient.
So you didn't go to your own hospital?
No.
You went somewhere
I went
else?
someone else.
Why did you go somewhere else? Was it just the queues or was it just because you just didn't want to go to your
I
health?
didn't want to go to my facility, not because I wasn't giving good care,
Okay.
but I wanted to be on the other side. Because now if I go to my facility, I don't want to feel woye for the other people I'm feeling for.
Oh.
So let me go and be a patient or a client, let me put it that way.
Okay.
Then they have to give you the details the same way they give to another patient. You're like, tick that, tick that.
Yeah.
Then COVID-19 positive, what do you do? Self-isolate. Because now you have a child at home, you have family.
Yeah.
Even me, I had the whole phobia of being isolated somewhere else. So I preferred to self-isolate. Because even I had a 4-year-old child then. There were symptoms. So I wanted to be here. Let me see what will... At the end of the day, I'm a nurse.
Yeah.
I can't assist other people. So for some time, I was at home.
Yeah.
Yeah, then it hit me. But I didn't get to the severe, thank God.
Okay.
But I managed it through.
I am just imagining being a healthcare provider. And then one moment it just switches, you switch positions.
Switch button.
And then you have to also be able to make sure you protect your family.
Yes.
At the same time, you're taking care of yourself.
Yes. Now you actually feel what patients feel.
Yeah.
What the demands of a patient now sound real. There are times they want you to tell them that. So you also want somebody to tell you that. You keep the professionalism, the knowledge aside. Now you have to go through the process. Yes.
Prof, when we hear, for instance, Esther's story, as a public health policy and decision maker, and as the president of National Public Health Institutes, how do you see issues around healthcare service provision and protection of healthcare, healthcare providers?
I think as Africa now, we are getting better prepared. What has happened where we actually realize that health workers are at risk. I think one of the things, of course, which are we have done, and I think that should be done, is number one is to look at the readiness of facilities to actually handle these emergencies. How ready are the facilities? So when you look at the readiness, we are looking at all the pillars, all the components in terms of the workforce itself, but also the environment in which they work, the countermeasures. Do they have the PPEs that we've been talking about? Do they have the skills to handle? Do they have high index of suspicion? And are they handling all these things like, you can have an outbreak occur? Because one of the things, of course, is hand washing, which we've seen in facilities. Hand washing actually have been maintained. Sometimes I get disappointed that a few of them may not be working as well. But I can tell you that hand washing has been maintained. We had water before. Why were you not washing? So one of the things I think that we've done is that. The other one, of course, is the emergency plans that include continuity of essential health services. Health workers were torn apart. So how do we now ensure that these health workers know what to do? What kind of task shifting modules have we put in place to ensure that these health workers are not torn apart, but actually doing things right? So I think we've learned a lot of lessons where we've lost health workers, where we've had burnouts of health workers, and because the facilities, first of all, are not well stocked, so health workers were kind of innovating. You find you had to innovate, but now that is getting less and less. So I think health workers, for me, are now better prepared. The only thing, of course, is still probably their welfare. But there are many other things that, for me, I think we move towards the right way of doing it to ensure that they are. And then, of course, involving the clinical teams now in response. So the clinical teams are not just hidden there. So whenever we are making discussions, like in the pillar, the structures of response, we have the case management team. So the case management team, we are saying we are not going to have you there only during response. How have we prepared the other clinical teams within the health facilities to actually handle cases like that?
Did your understanding of maybe the disease, maybe a bit of understanding or better understanding of the science behind the disease, give you any kind of reassurance compared to an ordinary patient like myself? If I walked into maybe the hospital and I don't know what I'm dealing with, does it make any difference?
This is one time you wish you did not even have the knowledge. For sure.
Oh, seriously?
Yes. Because if you know the stages
Yes.
of the disease.
Okay.
So when you get to mild, what will happen tomorrow? Will I wake up in severe? So you, at some point, you wish you just go through the phase like an innocent Kenyan citizen or any other innocent citizen. But as much as when I get fever, this is where the knowledge helps you a bit. If I get fever, this is maybe the drug I can take. Now that helps. But knowing the progress of the disease, you don't wish to know the knowledge.
It's not a good place to be.
It's not a good place to be. No.